Hello, my name is Kristy Feeney. I'm the National Nutrition Manager for Quality and Safety with Quorum CVS Specialty Infusion Services. I'd like to thank the Oley Foundation for the opportunity to share our research. I'll be presenting on catheter-related bloodstream infection rates in home parental nutrition patients receiving sodium bicarbonate lock therapy compared to ethanol lock therapy. I have no disclosures to make. I'd like to begin by giving a little background on lock therapy. Lock therapy is when a solution is placed into the tubing or lumen of a patient's central line catheter to prevent or treat a line infection. The solution will sit in the catheter, or you may hear it referred to as dwell, when the patient is not receiving any medications or infusion. The idea is that the solution will kill any bacteria that may enter the patient's central line, thereby avoiding an infection. And as you read about this, you may hear reference to a biofilm, which is the bacteria sticking together to create a cluster, almost in a protective shell. Prescribers may order lock therapy when a patient has a long-term catheter and has experienced multiple infections despite having good aseptic technique. Ethanol is one of these solutions used as a lock therapy for the prevention of catheter-related bloodstream infections, or CRBSIs, in the home parental nutrition patient. In 2018, ethanol experienced a significant price increase after the FDA approved it for the use in adult patients with a specific cardiac condition. One study estimated that the cost jumped from $10 to $1,000 daily. Complicating things further is the lack of reimbursement for ethanol locks in home infusion, as it is no longer being used for the FDA-approved indication and is now considered off-label use. This led to a gap where prescribers and institutions started searching for a safe and affordable alternative, one of those being sodium bicarbonate lock therapy. We wanted to explore in our HPN patients who were utilizing sodium bicarbonate locks if it was as safe and effective of a therapy for the prevention of CRBSIs as found in another study on hemodialysis patients. The objective of our study was to determine if there was an association between CRBSI rates and the use of sodium bicarbonate lock therapy compared to historical case controls using ethanol lock therapy. Historical case controls just means that we use the same patient to evaluate the different therapies. So for example, patient's X data is collected from when they received ethanol lock therapy, and then again, patient X's data is collected from when they received sodium bicarbonate lock therapy. Our study involved 9 pharmacies over 7 states. We included both adult and pediatric patients who were on HPN, and they had to be on 70% ethanol lock therapy and later changed to 8.4% sodium bicarbonate lock therapy, which are both commonly prescribed lock therapy orders. We retrospectively collected the data from the electronic medical charts within 2 12-month time periods, one beginning in January 31st, 2019 through January 31st, 2020 for the ethanol lock therapy, and the other beginning June 1st, 2020 through June 2nd, 2021 for the sodium bicarbonate lock therapy. The primary outcome was the average incidence of CRBSIs, or how often infections occurred, in 1,000 catheter days. And you can see from the table here, the list of criteria which was used to determine if a patient met that standard of having a CRBSI. We then compared the average CRBSIs in 1,000 catheter days for each of those 2 12-month time periods when they were receiving either the ethanol or the sodium bicarbonate lock therapy. And we set a p-value at 0.005 to indicate statistical significance. Our study population had a total of 24 patients. At baseline, the average patient was a 7-year-old male. In fact, our study is more generalizable to the pediatric population as they made up 83% of our patients in the study. The primary indication was short bowel syndrome with a median of 1.8 years on service with quorum for HPN therapy. This is a continuation of the previous table, and as you can see, most of our population had central venous catheters with a single lumen. In our TPN therapy characteristics, we found most patients infused daily over 14 hours, and we found that 75% of our population had multiple infusion therapies, which is another known risk factor for CRBSIs. Table 2 dives into the specific characteristics of lock therapies, comparing the frequency, volume, and dwell time. Both the ethanol and sodium bicarbonate lock therapy were provided 7 days a week. There was a minimal difference in volume from 0.6 mils in ethanol versus 0.5 mils of sodium bicarbonate, and a 1.5 hour time difference in dwell time from the ethanol to the sodium bicarbonate lock therapy. And as you may recall, dwell time is the amount of time that the solution is sitting in the catheter lumen. It can vary based on the prescriber orders, but it can be up to the length of time when a patient is not infusing their HPN therapy. The results found that the mean CRBSI rates per 1,000 catheter days was 0.64 for the ethanol group versus 0.59 for the sodium bicarbonate group. This is not a statistically significant difference. So what does this really mean? It means that when we looked at an average of all 24 of our patients, we found that both the ethanol and the sodium bicarbonate lock was less than 1 infection in 1,000 catheter days. And the standard of 1,000 catheter days is used across most, if not all studies, so that we can compare using the same unit of measurement. We want that number to be close to zero so that we don't see any infections in our patients. And when looking at this type of data, the larger the number of catheter days, the better the picture of how effective the lock therapy is. So to drill this down just a bit further for you, our patients had 6 CRBSIs and 7,500 catheter days on ethanol lock therapy, and 4 CRBSIs and 5,800 days on the sodium bicarbonate lock therapy. So our conclusion was that both the ethanol and the sodium bicarbonate lock therapy may be effective in preventing CRBSIs in adult and pediatric patients receiving HPN. When we compared our mean CRBSI rates to another study on bloodstream infections in HPN patients, both the ethanol and the sodium bicarbonate lock therapy were well below their average infection rate of 1.4 to 2.0 per 1,000 catheter days. It was exciting to see that there might be more options for our patients, but of course, more studies are needed. We'd like to see adequately powered and randomized controlled trials done to really evaluate the safety and efficacy of using sodium bicarbonate lock therapy as a means of preventing bloodstream infections. And additional studies are needed to determine the optimal sodium bicarbonate lock therapy protocol, including the concentration, frequency, and dwell time to prevent CRBSIs. All studies have their strengths and limitations, as does ours. As far as limitations, we really want to stress that the retrospective design of our study only allows for an association. It does not prove cause and effect, as there could be other reasons impacting the outcomes with sodium bicarbonate data. But our takeaway remains that it is promising and should undergo further evaluation. Additionally, we had a small sample size, which was composed mostly of pediatric patients. So again, additional studies are needed to determine its effectiveness in an adult HPN population. Strengths of our study included the length of time, using a 1-year period to evaluate each therapy, and thereby a combined greater than 13,000 catheter days. It was multi-state and multi-site, meaning it accounted beyond a single prescriber or institutional practice or geographical location. And finally, using the same people for the evaluation of both lock therapies meant that they likely had similar, if not the same, risk factors for developing CRBSIs. This may include their clinical condition, HPN formula, administration techniques or other behaviors, their exposure to more than one infusion therapy, and the notable similarities in their lock therapy for frequency, volume, and dwell time. Thank you again for the opportunity to present our study. These are my references. And finally, I want to say thank you to all the contributors to this study. This would not have been possible without their involvement. Thank you so much.